Hi, my name is Brittany Porter and I'm a graduate student at Washington State University. One change I'd like to see amongst my organization is a reduction of catheter line-associated bloodstream infections. In 2017, our hospital saw an increase in hospital-acquired bloodstream infections, particularly in these areas: the neonatal unit, intensive care unit, and medical surgical unit. And in my opinion, one case of preventable hospital-acquired infection is just too many. The problem is catheter line-associated bloodstream infections are associated with patient morbidity and mortality, prolonged antibiotic use, multi-drug resistant infections, and cost. The current practice amongst our organization is nurses are using alcohol pads to disinfect port sites on catheters and IV lines. They should be scrubbing the hub for 15 seconds with a dry time of 15 seconds before medications are given or flushing of the line. But are nurses really doing this properly? Or are they doing it at all? And how is this being measured? Well, I can assure you it's not, and I've witnessed it, and something needs to change. The problem with the current practice is nurses don't often know how long to clean the site with an alcohol pad, or nurses feel like 15 seconds is too long to clean the access port when using an alcohol pad, or nurses simply fail to scrub the hub because they choose not to or think it doesn't matter. In an emergent situation, who has time to scrub the hub before an administration of a medication? And most often, ports appear clean, so they don't think they need to be wiped down. This is bacteria cultured from an unprotected IV port. So when you think the IV port is clean, it's really not. These are strategies for prevention from the CDC: removing unnecessary central lines, following and facilitating proper insertion practices, complying with hand hygiene recommendations, adequate skin antisepsis, performing adequate hub/access port disinfection, and I highlighted this because this is the one focus I want our organization to put as a priority. Providing education on central line maintenance. This is a case study from England where they took over 1,000 patients over a 6-month study, and they audited port protectors on the oncology unit, ICU, surgical wards, and geriatric wards. And nurses use a technique of scrub the hub versus alcohol-impregnated port protectors. With the use of the port protectors, bacteremia decreased by 70%, and that's with a staff compliance of 80%. Bacteremia kept on decreasing with improving compliance of alcohol-impregnated port protectors. So this just shows that they really work. Implementing change for prevention amongst my organization, I'd like to see us purchase alcohol-impregnated caps or port protectors. I'd like to implement use of on certain units, those with higher infection rates, such as the neonatal, ICU, oncology, and medical surgical units. Provide education to staff on current CLABC infection rates and use of port protectors. Create a sense of urgency for use amongst staff. Find volunteers to be port protector champions to do audits and encourage staff use. Follow infection rates over a 1-year period of time, and reward units with the greatest compliance and decrease in infection rates. The benefits of use is that it's convenient and easy to use, and it saves time. It reduces infections, and it saves lives. Here I have an IV line. Here's a port, and here's a strip of the alcohol impregnated caps. And I just want to show you how easy it is. So you just pull it off. You can just put it onto the port. It twists on very easily. You keep it on for 1 to 3 seconds. It'll disinfect the port site. It can be left on for 7 days and continue to clean the and disinfect the port site. And then you pull it off and you can flush the line. That's how easy it is to use, and I would highly recommend them. Some people might find an obstacle would be the cost. The cost of 200 count box of alcohol pads is 99 cents, and the cost of one alcohol impregnated cap is an average of 27 cents. So why should we spend more on these caps? Well, you can see the change. Visualizing the caps, you know that our patients are safer from infection. It can be measured. Audits are easier to obtain when you can see the caps on the patient IV lines and central lines. And the average cost of one CLABC is $45,000. And not to mention preventable harm to the patient. Target zero. As an organization, our goal should be zero catheter line associated bloodstream infections. Through the use of port protectors and staff compliance, a difference can be made by saving the lives of those we care for. Thank you for listening, and here are my references.